time out of your busy schedules to join us for this 60-minute web session. Before we begin, I'd like to let everyone know that Zoom has been experiencing some technical issues due to an increased load on their servers with so many people working from home and the school districts conducting e-learning via this platform. So if you experience any issues throughout the session, please make sure you send us a quick comment and we'll see if we can get it resolved. I also want to let you guys know that we are recording the session. So within the next couple of days, it'll be available to you for review if there is a technical issue. All right, now let's cover a few housekeeping items. All attendees have been placed on mute in order to eliminate background noise. We encourage you to interact with our speaker throughout the presentation by typing your questions and comments into the Q&A panel. Your questions will be answered following the presentation as time permits. We may not get to all of your questions live, but we will be providing you with an FAQ document with the questions and answers received throughout today's session, as well as the PowerPoint presented and a link to the live recording within 5 business days. Today's presenter is Wendy Kennedy, Director of Revenue Integrity Services here at Vitalware. Wendy, the show is yours. You now have the floor.
All right. Thank you, Julie. Good afternoon, everyone. Thanks for joining us today. I know we have a lot on our plates and we might be a little out of sorts, but hopefully we can, take a few minutes and think about just some good CDM stuff. So like Julie mentioned, we're going to talk today about 4 reasons that we encourage you to conduct an annual CDM review. I'm sure most of you have seen this slide many, many times during our presentations. This is our disclaimer statement that basically states that this webinar presentation is current at the time it's published, and it's designed to provide accurate, authoritative information in regard to the subject matter covered. The information provided is only intended to be a general overview with the understanding that neither the presenter or the event sponsor is engaged in rendering specific coding advice. It's not intended to take the place of either the written policies or regulations. And we encourage participants to review specific regulations and other interpretive materials as necessary. So let's go over these learning objectives. So the learning objectives for this webinar are to identify 4 reasons to engage in an annual chargemaster review. Obviously, there are many reasons to do a CDM review, but today I've chosen to talk about the 4 listed here: compliance, reimbursement, revenue capture, and transparency. Both the Office of the Inspector General and the Centers for Medicare and Medicaid Services recommend that a hospital's compliance plan include both internal and external auditing to ensure compliance with regulatory requirements. So I'm going to begin the presentation first covering, excuse me, compliance in the CDM, as this should always be our main focus. But I'll also dig into each of these other extremely important areas that greatly impact the chargemaster. And I'll share with you why I feel these are solid reasons for performing an annual CDM review. And as always, try to sprinkle in some examples of some issues that we have identified during our previous client engagement. And at the end of the presentation, I hope that you have been provided with some topics for internal discussion, and then also maybe some great content to share with your leadership team if, in fact, you're hoping to obtain approval for engaging with an organization such as us to perform an annual CDM review at your facility. That being said, when I was putting these slides together, I probably got about a quarter of the way through and decided that it might be a great idea to come back more towards the beginning and just kind of give you guys a very brief overview at a high level of what a VitalWare CDM review looks like. I think that this will kind of give you a foundational information for understanding, why we chose these 4 things and how we see these items being important through the work that we do and the outcomes that we have for our clients. And so just to give you a high level view of our services, the first thing that we do is ask for a CDM download of your chargemaster file and 12 months of revenue and usage data. We also can get from you your supply and pharmacy file. Those are the 2 big ones that we receive from most of our clients, so that we can analyze those as well, especially if you're in an Epic environment and using shell records, then we can get to those individual line items in those ancillary files. Well, we get that data from you. We put that into our Vital CDM technology and perform our analysis using that technology. And I think currently we receive about 30 reports out of the system that help us to get started on analyzing all of that data. And so, we're going to be able to quickly find outdated or deleted CPT and HCPCS codes, revenue code CPT mismatches, some pricing that's below the APC payment, identification of some maybe primary and add-on services that might be missing from your CDM. So the technology provides us with just a wealth of knowledge to get started in analyzing all of these files. And then once we go through all of that, one of our revenue integrity consultants or a team of them, depending on the size of the engagement, will go line by line through every line in that chargemaster, making sure that everything looks to be complete and compliant, and ensuring that the CPT code assigned to each charge line actually represents the service described. We also always like to perform a claims review along with our CDM review so that we can not only see, the charges available to be utilized by your organization, but also see how's it working. Do folks know how to charge for the services that they're providing? Are the claim forms actually populating correctly? Is that whole process working? And then are claims getting manipulated accurately when perhaps they get through the scrubber or fail for some reason? So after we've done all that off-site work, gathered all that data, we come on site to your facility and have discussions with revenue integrity leadership and the clinical leaders for each clinical department to really discuss not just the individual charges in your chargemaster, but also what that process looks like at your organization. So we really want to have a thorough understanding of how do charges get into the system, what mechanism is each department using for charge capture? Is there any kind of check and balance in place, like charge reconciliation, to ensure that everything is working as designed? And so that also can help us, once we have a really thorough understanding of how things work, we may be able to get to the root cause of some of the findings that we've seen in both the CDM review and the claims analysis to be able to help you make those corrections very quickly. Once we come back from that on-site visit, we compile all of this information. We do load that into our Vital CDM tool through the workflow process for you to be able to process it there and make those changes in the actual CDM file. And then also provide you with a narrative executive summary of those findings and recommendations at both a high level and at an individual department level. Once we've gone over that report with leadership, we do provide support to our clients for 6 weeks, just so that we can ensure that we're available as clients are going through making changes, making adjustments. We're here to answer questions. We're here to brainstorm. We're here to provide education, anything that you might need in that 6-week period following the delivery of those results. So hopefully that makes sense, provides you with a little bit more information of, how we do our work, what we're looking for, how we're able to help clients, like I said, not only with the chargemaster itself, but also, charge capture accuracy and maybe even some revenue integrity process improvement. So let's talk about compliance first. So as I stated previously, our main focus as members of the revenue cycle team should always be compliance. Obviously, we're all tasked with, KPIs such as daily revenue, AR days, your DNFC, your discharge not final coded, your DNFB, discharge not final billed, clean claims accuracy, and denial rates. Those types of things are on our plates on a daily basis. But in our daily work, our focus should always be on performing tasks in a manner that meets the regulatory requirements of billing for the services provided to patients. And as part of our CDM review activities, we regularly validate the accuracy of the data elements within the chargemaster, as I said, pharmacy and supply files, like the CPT and HCPCS codes, those revenue codes, modifiers, drug multipliers, the national drug codes or NDCs, and the comprehensiveness of charge descriptions. So, talking about those charge descriptions, we oftentimes might make recommendations to, add additional verbiage or content to the description that provides a more clear description of the service. So some examples of that might be that something can be charged for each, but that each isn't in the description. So when a clinician or a charge entry person goes to choose that, adding each at the end makes it very clear to them that they can put that charge in more than once. Other things that we might recommend is, for laboratory services, when there is a test for resulting both a quantitative versus a qualitative result, adding that verbiage to the description to make sure that those differentiators are very, very clear. Up to 2.5 centimeters for laceration repairs, or even per milliliter for maybe your contrast charging. Just to ensure, again, that it is very clear which charge represents which service and how to appropriately charge for those items. This is also very helpful. The more descriptive that those descriptions are, it's super helpful not only for external folks that do charge capture auditing for you, but also just internally when you're looking at claims to have a much better understanding of exactly what was charged. This also obviously is a great way to determine, be able to validate that the CPT code is accurate for that description. So when we're doing our work, if we feel that we've identified a discrepancy between that charge description and the CPT code, so, we're reading the charge description, we're looking at the CPT code description, and something seems to be out of sync, we will have detailed discussion surrounding that with both the revenue integrity and those clinical leaders during that on-site visit to determine if in fact we found something that needs to be corrected. We will make those recommendations and educate folks on the ramifications of that, and also just, how it should be done correctly. So maybe that education is to the clinical department or even with the CDM folks. Because remember, our main goal again is ensuring that we are following compliant billing practices. So submitting performing a chest x-ray and submitting a code for a spine x-ray is obviously a compliance issue, and other issues as well, as far as reimbursement goes. So again, making sure that all of those things are in sync so that you can be confident that the bills going out the door for your organization are accurate. We also encourage our clients, to have further discussion internally when we do find something, to, really come up with a plan on when these compliance issues arise. What is your response going to be? When do you bring in the compliance department and have those discussions? What analysis did you perform to, quantify the financial impact of those issues, and either self-report or perhaps rebill accounts to get those corrected. So you'll rarely hear a conversation about compliance without hearing the word risk. And so you'll often hear, what is the risk to the organization if we do this? What if this happens? What is our risk? CDM, CPT code assignment carries a high level of risk, since the CPT code drives the reimbursement in most instances. CPT codes are assigned in the chargemaster, but also by coders. And so that case-by-case assignment of codes by a coder carries a slightly lower risk than the assignment of a CPT in the chargemaster. And not that one is more important than the other, but once that CPT is assigned in the chargemaster, that is no longer applied typically on a case-by-case basis, but rather every single time that particular service is performed, that CPT and the chargemaster is going to go on your claim. So it is imperative that the codes assigned in the CDM are correct and that charge capture accuracy rates are high. You want to ensure that you're self-checking. Get yourself on, a regular audit schedule to ensure that, you're keeping that charge capture accuracy rate high. I see kind of some peaks and valleys as hospitals trend this over time, which, has a lot to do with staffing. So you may have new staffing coming into a department, and maybe during their orientation, they miss some pieces and parts of their training, and they lack some information on the proper way to charge or the proper way to enter orders. And this can result in, a great run of great charge capture and then a big dip where something has gone wrong. So keeping on a regular schedule of internal auditing is really recommended to not only ensure your revenue, but obviously, nip any of those compliance issues that you might identify in the bud as quickly as you can. And again, inaccurate codes result in incorrect payment, but that risk that we're talking about, that risk increases if that code results in a higher payment than what you should be receiving. Clear and concise documentation. Obviously, this is necessary to support the charges on the claim. The medical record is, after all, the legal document of truth for each patient visit. And so some examples of documentation issues that we've identified during claims reviews, drug administration start and stop times. This has greatly improved over the years, especially with the technology advances that we have to capture documentation. But we do still see some of our clients struggling with this from time to time. And I think, again, sometimes that can be technology-based, or that could be, human-driven. And so staying on top of that and re-educating, identifying any of those system issues that are causing a problem and getting those adjustments made very, very quickly is obviously going to reduce your risk of any large compliance issue. Documentation of contrast. We see docs are great about dictating that they used contrast, but there are times when we fail to find anywhere in the medical record how much contrast was actually administered. So really keeping an eye on that documentation, and anytime you're identifying any of those deficiencies, making sure that you're getting out there and educating the importance of this documentation. We also sometimes see discrepancies in observation time. And so the mechanism that some hospitals use to calculate observation time and what we see in the medical records sometimes are conflicting. And then sometimes with any of those carve-out type items where you're carving out those monitored procedures, sometimes there's just a lack of documentation of what that time is. What is that amount of time that occurred for that monitored procedure that I should be removing from the observation hours? So again, this documentation to support the services that we bill for is extremely important. And bad documentation just increases risk. The next risk that we identify relates to charge explosions. I've heard some hospitals have tried to move away from this, but it is an efficient practice that makes people's lives easier. But we often may find that the explosion is outdated. So maybe one of the children charges has an old CPT code, or even perhaps technology has changed. So the technology utilized to perform certain procedures has changed, and that charge explosion, so linking all those things together, hasn't gotten updated with the new technology. So maybe a different technology is being used, but that charge explosion maybe still uses ultrasound guidance when that's not what we're doing anymore. So, having a schedule to review those charge explosions on a regular basis to ensure that they're up to date and accurate. We found a case recently, a situation recently with an organization that we worked with where they had a charge explosion for an IV insertion with an ultrasound guidance, but the guidance included the wrong guidance charge. And so, thinking about that, every time, that charge was used, it was inaccurately reflected on the claim. Fortunately, the status indicator is the status indicator N, and no additional reimbursement was received, but still inaccurate. And so getting that updated was super important. And then with the use of preference cards, we sometimes see that clinicians fail to remove charges for supplies that were not used during the particular procedure associated with that preference card. So keeping a close eye on if you're identifying where you've got tons of supplies and you just aren't seeing that any of that was used, that could be the root cause causing that issue. And then the next bullet here is very important for reducing risk. Proper response to failed claims. I could probably talk about this for hours, but it's extremely important that you are not increasing compliance risk by working failed claims inaccurately. This includes properly assigning those modifiers like the XS, XU, XE, and XP, since those have a direct impact on allowing you to get additional reimbursement for something that was done at the same time as something else. So, really ensuring that those are applied appropriately. Again, when we are looking at claims, we often identify that staff have added those modifiers. You know, they reviewed a few cases and it seemed to be appropriate. And so from then on, every single time that issue arose, they applied that same modifier over and over and over again without necessarily validating that in that particular instance, that modifier was actually appropriate. And so, you know, keeping in mind that just because a modifier is allowed with with a code combination, it does not necessarily mean that that modifier is appropriate on every single claim. And so really making sure that the folks that are working those failed claims have a really great understanding and are working those on a case-to-case, case-by-case basis with folks that are trained because CCI edits, you know, those types of issues. And so making sure that those functions are assigned to folks that understand the guidelines associated with when codes can be used together and when they cannot. You know, at VitalWare, speaking of modifiers, we don't encourage hard coding these X modifiers in the chargemaster as a best practice, only because the risk is high if it's done inappropriately. And so we really encourage our clients that we work with to have a person review each account and determine, based on documentation in that current situation with that particular account, whether or not applying those modifiers is actually appropriate. The last bullet here, proper linkage between your order entry or clinical systems and the CDM. This is key to ensure that what's being ordered and performed is actually what is being charged. So I love that our tool has the capability to pull in ancillary files and actually view the linkage between the two. We can also see in an Epic Willow file, we can see which drug is associated with which shell record and see all of the drugs associated with that shell record. So just lots of visibility of those types of items. And so, you know, when is the last time you looked at that? When is the last time you validated that the linkage between these two systems is actually accurate? During our reviews, we do find incidences where orders are linked to incorrect charges. They're linked to something completely different than what they're actually ordering and performing. And then sometimes we find, you know, reviewing that revenue and usage data as part of that CDM review, we can identify things that just look kind of out of sync to us. Maybe the usage is very low on something that we would expect to be much higher. That drives us to that conversation. And we may find during some research on site that, you know, the order isn't linked to anything in the chargemaster. And so basically every time that service is ordered and performed, it's actually free. So that's resulting in, you know, obviously a financial impact to your organization. But again, you know, not even demonstrating your cost. So again, focusing on compliance, it's imperative that, you know, what's being ordered and performed is appropriately represented on that claim through the mechanism of charge capture and CDM maintenance. So next I want to touch on CDM review and reimbursement. So obviously, I think we all know that an accurate and comprehensive chargemaster is key, a key foundational element to receiving appropriate reimbursement. I've listed here several items that have a direct impact on reimbursement. You know, outpatient reimbursement in general is typically based on the CPT HCPCS revenue codes and perhaps percentage of charge. And so, you know, that makes it imperative that these data elements are accurate in your chargemaster to ensure that proper reimbursement is realized. OPPS APC payments are calculated on CPT and HCPCS codes, you know, making it impossible to get paid correctly if your CDM is outdated or incorrect. You must always ensure that the alt code, so that alternative HCPCS code that Medicare wants, is built appropriately in your chargemaster, so that when that goes to populate onto the UB, it's pulling the HCPCS code that Medicare wants. Otherwise, you know, you're going to have lots of RTP claims. I have actually seen some providers process those claims incorrectly, and then rather than RTP, then it's resulted in denials. So, you know, keeping on track with validating the results that you're getting back from your payers to make sure that they have adjudicated those claims correctly. It's going to have a big impact on your reimbursement. Status indicators, those are super helpful in determining which codes are not billable to Medicare, so that this information can be used when you're assigning those charges and building charges in the chargemaster, you know, in your efforts to help reduce failed claims. I've also added, you know, modifier here, since again, you know, adding a modifier can in fact increase your reimbursement for a claim. And on the flip side, we can sometimes see, rather than adding a modifier when we see a failed claim, sometimes we see that someone just reversed the charge altogether, when in fact it's clearly documented and absolutely appropriate if a modifier is applied. And so, you know, really ensuring that people have a really clear understanding of all of these guidelines and that they are reacting to issues that arise, you know, in an appropriate manner. The next data element that is directly tied to reimbursement is units. So ensuring that units that should roll to 1 on the claim actually do. So oftentimes in the OR, we're charging by time. And so, you know, you may have 360 minutes in the OR, but obviously you don't want to charge 360 units of an appendectomy, since that is anatomically impossible. But validating that those units are rolling to 1, but then on the flip side, you know, looking at your pharmacy drugs and making sure that those drug units are converting from the way they're built in the chargemaster to the way that J code is represented and should be billed on the claim. So validating all of that information to ensure that you're not getting paid for 1 unit of a drug when you should have been reimbursed for 400, but your multiplier is built incorrectly or non-existent in some cases. This is something that, you know, we look at on our claims to make sure that we can help clients identify any of these issues, and also just ensuring that those things that folks think are happening are actually happening. So, you know, tracing that data from charge entry or order entry all the way through the process onto the claim to make sure that we have the actual opportunity to get paid correctly. And then the last bullet here is price. And although in most cases, you know, Medicare is going to pay you the APC rate, even if you're charging them less than that payable rate. But this is not the case when we're talking about managed care payers. So most of those managed care contracts include that lesser of language, meaning that they will pay you the rate that you've negotiated with them unless you charge them less than that negotiated rate. And if you do, then they're going to pay you less. And so, you know, keeping a check and balance process in place for keeping those prices in line so that, you know, you're reflecting your costs, but also ensuring that you're not shooting yourselves in the foot from a reimbursement perspective and undercharging and obviously, getting under reimbursed. And, as part of our review, we do have the ability to compare your prices to the APC and the fee schedule rates, to your peers, your state averages, and even percentiles, so that you can evaluate your current comfort level with the current pricing structure that you have created. So lots of data that we have access to be able to help you through making some of those decisions. Because the basis, for all of this is that, hospitals want to be reimbursed appropriately, not too little, but also, not too much. We don't want to put ourselves into a compliance situation. Next, we have revenue capture. I know I've stressed before, that kind of, compliance is king, and it is. But revenue capture is key to compliance and reimbursement. Fundamentally, the goal is to capture and appropriately communicate the cost of the services that you provide. And our CDM review can identify missing charges. In other words, charges for services that you perform, but they're not currently in your CDM, therefore you aren't currently charging for them. Excuse me. This might occur due to a simple lack of understanding of the charging guidelines, or perhaps I have seen where the department never asked for the charge, and so the revenue integrity team is not even aware that the service is being performed. And so obviously they had no knowledge to know to build this charge. And so having a really solid process for CDM maintenance is super important, and having regular contact with between revenue integrity and those clinical departments is super important to ensure that you are capturing your cost and getting all of that revenue allocated. And obviously, I mentioned before, sometimes the order exists on the clinical side, but the order isn't linked to anything on the chargemaster side. And so getting that new charge created to capture those costs, and then also getting everyone educated, getting the system set up to be able to link those items together to make sure that things are orderable and chargeable. Our software allows us to identify missing charges through those reports that I mentioned earlier that can help us identify when there is a primary service in your current chargemaster, but there are add-on codes to that aren't currently there, or vice versa, where the add-on CPT code is listed, but there isn't a primary. So our technology helps us very, very easily identify those circumstances. And, one of those, like for instance, one I see quite often is those biopsies where there is a code for each additional lesion. And oftentimes folks will inappropriately charge for that initial biopsy more than once. Again, results in a failed claim. Somebody might assume that that's just an error and strip one of those off. The bill goes out the door, and you've missed the opportunity for that additional lesion. You haven't captured the cost of providing that service, and you have zero chance of getting paid for that as well. Through claims reviews, also through that revenue and usage data, we can identify missed charges for services that are provided and are appropriately documented. So missed, or sometimes called lost charges, are typically human or system driven. And when we identify patterns of mischarges, we do bring those examples up during that on-site visit so that we can help our clients, identify the root cause of these mischarges. We might identify that the clinical staff responsible for charging the service, or perhaps charge reconciliation staff, if those are different, might need additional education on understanding how to appropriately charge for the services they're providing. We might identify that the mischarge is caused by one of those linkage issues in the system, or even some kind of system glitch where something's been working as designed, and then halfway through the year, that revenue tanks, and we identify that through looking at claims and seeing what the problem is. Sometimes we find too that mischarges were there and they got credited back for some unknown reason, and need to be researched as to, who's crediting them, what was the cause of, what caused that person to think that it was necessary to credit it back. And then again, education is key to sharing all of these findings with the staff that do this work to ensure that everyone has a really great understanding of how all this works. I think too, sometimes people tend to work in their little bubble and they may not understand the ramification of something on the back end. So sometimes clinicians don't understand, how hospitals get paid and the importance of every single charge getting on that bill. So ensuring that, folks are educated. Late charges. Late charges can result in lost revenue in situations where, some organizations have late charge policies. And so the charge amount of the late charge is below a particular rebill threshold. And so that revenue is just lost. It's not going to be rebilled and thus not recovered. Or perhaps that late charge was identified at a time period too far past the bill date for your organization. And so again, you make the determination not to go ahead and rebill those accounts. And so in those situations, late charges cause organizations to leave some money on the table. And so the key to reducing these late charges again, comes back to getting to the root cause, rolling your sleeves up and digging in and what is causing the problem, making adjustments in the process, maybe it's a process issue, or again, providing that education and then resetting expectations. Keep hammering to everyone how important charge capture is to cover your cost. Late charges should be tracked and monitored to keep those at a minimum, and then obviously readdressing any of those issues as you start to see those tracking upward, getting on that quickly and readjusting, re-educating, performing additional root cause analysis to identify why those things are happening. And so again, I want to talk about failed claims. I'm probably kind of an odd bird. I really like working failed claims. I think that each one of them is its own, mini puzzle. You're tasked with, finding the issue, why it occurred, and then correcting that. And then again, what's the next step? So I fixed this one account. Am I seeing a lot of these? Do I need to tell people? Do I need to communicate, to educate, all those things? When a claim fails and it requires human intervention, there's a high risk of working that failed claim inappropriately. And so, again, we're coming back to the same thing, modifiers, bypassing edits for the sake of, I know if I put this on this claim, that edit will disappear. And sometimes what I've seen is a modifier has been added and it's obvious that nobody reviewed the documentation because the charge that they modified was actually the wrong charge to begin with. So that particular service isn't even documented in the chart. That was chosen in error, and something else should have been charged in its place. And so, you know, this can create a compliance issue, a reimbursement issue, and then obviously, you know, a revenue capture issue when it comes to, you know, what's the price of the incorrect charge versus the correct charge? What's that CPT reimbursement going to yield you? You know, did you just get an extreme overpayment, or did you just get severely underpaid? And then let's not forget about, you know, we want to get all the charges in the system, but if we don't do it right the first time, then we're left kind of chasing our tail and spending all of this extra effort working failed claims, researching issues, making corrections. It can just be a really big cost to an organization to have to rework anything. So, you know, when we're working with clients doing these CDM reviews, you know, we try to talk about these issues, provide education in any way that we can to help our clients, you know, increase that revenue capture rate. I also added here underneath failed claims, you know, increased AR days and RTP. So, you know, if claims do not fail in-house, so maybe they're not failing in the scrubber, but then they go to the payer and fail, and Medicare, for example, returns that claim to the provider, then that cycle starts all over again. You know, why did they RTP this claim? What does the message from them say? Is that enough information to tell me what's wrong? What do I have to do? I need to pull up the medical record. I need to send this to someone else to pull up the medical record and review this case. So it's just that cycle of doing rework again that is going to increase your days in AR and slow down cash. So, you know, really focusing on getting things done on the front end versus chasing your tail on the back end. And then the last thing I've noted on this list of issues that impact revenue capture is see oftentimes organizations that are billing for both sometimes get confused, I guess, kind of get their wires crossed on the regs associated with each. And we have found, you know, charge errors that are simply caused by a lack of understanding of that. We worked with a hospital a while back that didn't charge for anesthesia because the response I got when I questioned them, you know, I don't see that you have any anesthesia charges. Do you not charge for anesthesia? Have you rolled that into the surgical fees? And they said, no, we don't charge for anesthesia because the anesthesiologist is the one who does that. And so we don't charge for that as an organization. And so, you know, we had some discussion about that. I gave them an example of, you know, we also don't perform the surgery in the OR, the physician does, but we get to charge for that because the cost, we incurred a cost for that service to be provided. So we've got equipment, you know, we've got anesthesia equipment that we purchase and maintain and replace, and supplies associated with that. And so, you know, the hospital is allowed to charge for those things to capture your cost. If you're lucky enough to have any percentage of charge payers, it's going to be even more important to capture, you know, every possible charge that you can. The final reason in our list of 4 reasons to do an annual CDM review is transparency. And as you know, hospitals are currently required to publish the CDM data out there on the web for the public, including services and prices. And with the new requirements coming to include a consumer-friendly display of shoppable services and maybe contracted payment rates, it's imperative that your current pricing policies are revisited. You know, these requirements impact hospitals, including critical access hospitals, inpatient psych facilities, sole community hospitals, and inpatient rehab hospitals. And those that are exempt from this include federally owned or operated hospitals like Indian Health Services, VA, and military treatment facilities. You know, CMS has published a listing of those 70 shoppable services, including some of those are, you know, E&M, which includes some psychotherapy, consultation, office visits, some routine lab, radiology, some routine surgical services like spinal infusions, tonsillectomies, colonoscopies, and obviously many, many more. But the thing to remember is that now everyone can see what you're charging. And so having really strong pricing, strong and consistent pricing policies is going to be key to survival in this competitive marketplace. You know, having this information, you know, our patients are going to be much more knowledgeable and be able to make, you know, sound decisions for their wallet by accessing this data online. And so, you know, really making sure that you're taking a look at your prices. What does Medicare pay? What does your other payers pay? I think one of the things that, you know, is going to create some real frustration for hospitals is, you know, posting negotiated payment rates. You know, nobody wants to show on paper that they charge $25,000 for a service that gets paid, you know, $3,000. And so, you know, these are different times, and this is going to get, you know, very, very interesting as we progress through these rules and, you know, shift the way we do business to be able to accommodate all of this. And so again, you know, we can help with that as far as some of that analysis, you know, pulling that data into our tool, comparing you to your peers, comparing your prices to your state or the percentiles, you know, the fee schedule payments, or even your own contract. And so I think this is the perfect time to kind of start digging into some of those policies and making sure that you're comfortable with the pricing policies that you currently have in place. Maybe it's time to do a level set of those and make some adjustments. So in general, you know, as healthcare organizations are required to operate in a much more transparent manner, sound, defensible pricing policies will continue to remain a focus going forward. So super important to consider your current pricing strategy, what that looks like, how comfortable are you with it. We can do some analysis here, this last bullet, on your cost to charge for, you know, supplies. You can provide us that data. We can do some analysis for you there. So hopefully today I've been able to demonstrate to you that, you know, there's certainly a great value in partnering with an organization like VitaWare to perform your annual CDM review. You know, the CDM really is the foundation of hospital revenue, both gross and net. And the interactions between the chargemaster and many other systems within your hospital can get quite complex. You know, as I know I've probably said this on every webinar, but as technology advances, we've got some pretty slick things that we can do in healthcare, but that also provides us with a level of risk that, you know, we could get a hiccup in our technology. And so really having a great strategy to validate this information on a regular basis is super, super important. And like I said, from all perspectives, from compliance, from, you know, getting paid correctly, to also demonstrating your cost. So if you don't get it on the claim, you're not going to get paid for it. And so I hope that your compliance plan includes engagement with an outside auditor, like OAG and CMS recommend. And I encourage you, you know, obviously I would love for it to be VitaWare that you come to talk to, but, you know, I definitely encourage you to think about some of these things and start some dialogue in your organization. And then, you know, bring some of this information to your leadership. When was the last time you actually had a full comprehensive chargemaster review, something outside of doing your quarterly updates and really digging deep to make sure everything is functioning as planned? So Julie, I will turn it back over to you to see if anyone has any questions.
You know, at this time, Wendy, first and foremost, that was fabulous. I gained a lot during this presentation, so great job. I'm sure others on the line did as well. We do only have 2 more minutes, so we'll go with one question. And just to be respectful of everyone's time, we will close the webinar, and feel free to reach out to us after the fact if you have any additional questions. And again, we are going to be providing everyone with an email that has a link to download today's presentation, an FAQ document with all of the questions and answers from today's session, as well as a link to the live recording, in hopes that you will share it, as Wendy mentioned, with the rest of your team members. So one question, first and final question. For your CDM reviews, do you visit on-site with all clinical departments?
We do. Our standard engagement, we've had clients request that we not do that. Sometimes that's just a preference, but we do. That is standard in our engagements, that we come on site. You know, if you're a fairly large facility, we might be there anywhere between 3 and 5 days. And so we will sit down with revenue integrity, you know, maybe have conversations with coding and other billing departments, perhaps, you know, those failed claim specialists, and really make sure that we have a really great understanding of what's happening. You know, the purpose of our on-site visit isn't necessarily to bring you the results of our analysis, but you know, we don't consider ourselves done yet. So we've looked at your file with, you know, some basic information from you. We roll up our sleeves, dig into all of that, look at those claims, see how things are working, come up with some topics of discussion, maybe some items for clarification. Obviously, we are going to bring to you any results that might be compliance issues that you need to get on right away. Anything that we think is kind of a weird glitchy thing where you have very low usage on something we assume you're doing, we're going to have those conversations so you can get started on researching those issues as soon as possible. Changing a CPT code, you know, from 2013, and you're doing it 4,000 times a year, we're going to be all over that, because somebody has to be fixing that code on the back end. So we'll share some of that, but it really is to have dialogue to better understand how things work at your organization. How is the chargemaster maintained? What is the relationship that those revenue integrity folks have with the clinical departments and the business office? And, you know, sharing also the results of that claims review, so that if we find that the sleep lab has a big problem, picking the right charge, we can sit down, show them examples, show them the documentation, and walk through that and provide them education so that at the end of that hour that we spend with them, you know, they can get back to their office and have a very good understanding of how to do it right. So they're very interactive. We also encourage our clients to, you know, bring your pain points to those meetings. So if you're struggling with a particular service that's being denied, or you've got a new service and you're not really sure how to bill for that, you know, bring all that to us. A lot of our job is researching on your behalf. So we'll get to the bottom, we'll get you the answers, we'll get you that supporting regulatory documentation that you can keep on file to ensure that you're doing that right and to use in education.
Okay, great, Wendy. Thank you so much. Again, for the sake of time, we're going to go ahead and close today's webinar. If you want more information on what you saw today, then feel free to reach out to me directly at events@vitalware.com, and we'll get you set up with all the appropriate needs and connect you with Wendy. To stay up to date with VitalWare's future webinars, we invite you to follow us on LinkedIn and check out our upcoming webinars on our website under the Reference tab. So again, thank you so much for joining us. We hope you found it very informative. I know I did. And thank you, Wendy. It's always a pleasure to listen to your intel. So thank you for sharing. And you guys have a great rest of your day, and everybody stay well. Thank you.
Thank you.
Bye-bye.